SAGES stories.
Welcome to today's episode of SAGES Stories, the official podcast of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. Please make sure to hit the like button and subscribe so you can stay up to date with our most recent episode. And enjoy the show.
Welcome back for episode 35 of SAGES Stories. I'm Dr. Kevin L. Hayek, tuning in after some whirlwind travel back in my lovely hometown of Cleveland, Ohio.
And I'm Dr. Jenny Shao, also back in Ann Arbor after ACS. So today is episode 35, and we're really thrilled to do a special episode on global surgery with two amazing leaders who've been building capacity, training teams, and delivering care around the world.
Our guests today are Dr. Linda Zhang and Dr. Grace Kim, both accomplished minimally invasive surgeons and educators, each with a distinct path into global surgery. We'll talk about their journeys, their initiatives, and how surgical societies like SAGES can help advance safe, sustainable surgery worldwide. Interesting, with all the travel that we all do, it was funny that we were all in Chicago just a few days ago, and three out of the four of us were actually in the same room. And I was joking with Linda that we should have just done this episode in person then.
Yeah, I know. Sometimes it's just so hard to get everyone together at a meeting. It's like herding cats or surgeons, I guess, which is kind of similar. But I'm glad that we have time tonight and that we get to talk about a really interesting topic.
Perfect. Well, I know many of our listeners will know our guests, but for those who don't, let's start with some introductions. First, Dr. Linda Zhang is a minimally invasive bariatric surgeon at Mount Sinai in New York City. She graduated AOA from the Icahn School of Medicine after studying anthropology and psychology at Amherst College. Next, she completed general surgery residency at Mount Sinai, earning multiple awards for excellence in clinical care and teaching, and then completed a fellowship in MIS in bariatric surgery at Washington University in St. Louis. Clinically, she focuses on foregut disorders as well as complex ventral hernias. She's got skills in laparoscopy, endoscopy, robotics, and open techniques. Beyond the OR, Linda has worked to reduce healthcare disparities, spending a full year in South Sudan implementing a community health program and participating in surgical work in the Dominican Republic, Haiti, Honduras, Ghana, and China. In SAGES, Linda has been the face of the GLAP initiative, which we will hear about in depth today. Linda, we're honored to have you.
Thanks, guys. That was a lot of introduction there. It's totally unnecessary, but
Yeah, and so joining her is Dr. Grace Kim. She is one of my amazing, fabulous partners here at Michigan, and she's also the clinical professor in the Division of Minimally Invasive Surgery and the director of the General Surgery program at Brighton Center for Specialty Care. She is the vice chair of education within our department and also the associate program director for the general surgery residency. She's a graduate from Yale and earned her MD at Weill Cornell and completed a residency at St. Luke's Roosevelt in New York City, and a MIS fellowship at UT Houston. Before she was here at Michigan, she also served as the program director at St. Luke's Roosevelt, and clinically she focuses mostly on hernias, GI tract surgery, gallbladders, and minimally invasive approaches. Dr. Kim has received numerous patient choice and teaching awards, including election into the Academy of Surgical Educators. Her research spans surgical education and global surgery. And among many topics, we'll also hear a lot about her highly successful All-Safe platform that she designed and expanded over the past couple of years. So welcome, Grace. We're really excited to have you as well.
Thank you. Thanks, Jenny. Thanks, Kevin.
Absolutely. So let's start at the beginning. So Linda, why don't you just tell us a little bit about yourself, your early years, and then specifically when along your journey you decided to become a surgeon and how that came to be.
oh, we are going way back then.
No, not that far back.
Well,
Not that far back.
um, Well, when I was in med school, I actually really loved surgery, but I was a little nervous and hesitant about going into it because back then there wasn't really that many female mentors, and it was a different culture, back then compared to now. It was a lot more male dominated, aggressive, and I wasn't sure if I was had the right personality for it. Around that same time, I was getting a little tired and sort of felt like I needed a break. And that's when I decided to take a year and go to South Sudan to do what I felt was maybe more impactful, meaningful work than staying in med school for then just, learning. So it was supposed to help me clear my mind and help me choose between surgery and something else, but it still didn't quite do it. And then it was a very last minute decision that I decided to go into surgery, but it was a very good decision because that was definitely the right move. So, yeah, so that's how I became a surgeon.
And then what specifically drew you to minimally invasive surgery and kind of where your clinical practice has landed now?
Right. That was also it was actually funny enough, a process of elimination. I didn't really like a lot of the other subspecialties, and I liked bariatric surgery and the fact that there is much more long-term relationships between patients compared to many other general surgery specialties. And I like the fact that I could see them for years and years and see how they're doing and see the progress that they have made. So, and in terms of my practice now, I really have to say that it's really based on my fellowship at WashU under Dr. Brunt, Michael Brunt, and Brent Matthews. I think they were very influential in sort of making both in terms of my clinical practice and also my involvement in SAGES. It really they really supported me in that, and that's how I am at the same time a maximally invasive surgery for ventral hernia open technique, and at the same time a minimally invasive surgery for all other things. So
I say MIM can mean both things in MIS.
yes.
I definitely use it for both minimally and maximally. So I think that's a great way to use the M.
Yeah,
Yep.
definitely. I agree. Yeah, actually, it's so funny. We talk about this on the podcast all the time, but I feel like everybody we interview says, like I'm not really sure why I went into surgery, but then I just fell in love with it. So I don't think you're the only person to kind of have that story. So Grace, what about you? Will you tell us a little bit about your pathway getting into surgery and minimally invasive surgery and specifically surgical education?
Sure. I think similarities to Linda. I did my medical clerkship first, which I actually really enjoyed. So I went through my entire clerkship year thinking I was going to do internal medicine until I did surgery. And then within just a few days, I think I realized that that was where my home was. Being able to operate obviously was a big component, but also just the decision making and just the kind of the facility of the whole thing. And I also, right about that time, I was also getting involved in global work. And my first couple of trips were purely medical and preventative care. And I think I recognized that surgery would also be able to more definitively help patients individually. So I think just the fact that I really loved my rotation, plus seeing how that might extend into global work, really kind of locked in the decision to do surgery. And I've loved it. I've had absolutely no regrets. I think if medical students are listening to this podcast, surgery has been just such an amazing journey for me. In terms of MIS, I think, at the time when I decided to go into MIS, it was the fellowship to do. It was kind of the cool one to do. I wanted to stay in general surgery, and I really liked the technical aspects of the field. So for me, it was kind of a pretty easy decision to do MIS. And then surgical education, you had asked about. So I think when I had my first faculty position, I went back to the institution where I did my training, and I was kind of the automatic teacher. in terms of didactics in the operating room. And I recognized that it was something that I really loved and felt that as I did it more, I got better and better at just being a teacher. So that kind of started the whole pathway of being a clinical educator. And I think the more that I did the boots on the ground educating, the more that I realized that there's a whole research behind it. So surgical education research is so huge, and there's a science behind educating well. And as I started to understand that facet of things too, my interest in surgical education grew.
I
That's
definitely can
awesome.
use some tips from you about surgical education. We have to kind of learn from you from that aspect for sure.
Oh, thanks.
Yeah, I've thankfully been a fly on the wall in some of those ORs in our trips, so I can definitely attest to that ability to teach others. So, and I've taken as much as I can, but still quite masterful.
You guys are very kind.
Well, we only speak truth. Um, so let's define global surgery. I think it can mean a lot of things. It can mean short-term trips, it can mean long-term partnerships, research, education, system strengthening. How maybe we'll start with you, Linda. How do you define it, and what is success in global surgery in your mind?
Oh, that's a great one. The first one is maybe a little easier to answer than the second.
Okay,
Um,
take the first one
global,
first then.
yeah. To me, global surgery is really about breaking down barriers and increasing the access to care to areas that have very low resources and don't have that ability to get surgical care. So a lot of that does involve a relationship and a collaboration between surgeons or doctors or personnel of a high income country with partnered with a low income country. I think global surgery overall has changed a lot over the last 20, 30 years. Like I would say before the 2000s, global surgery was really defined by very short-term mission trips. And I'm sure Grace also agrees with me on all that, that it was very short impact, low uh, and short and probably low impact activities where the surgeons themselves who go probably feel very good about giving back and doing something that they feel like they could contribute to, but probably very low impact and low sustainable change in the local environment. Whereas as time progressed in the early 2000s, I think there's been a real shift in how we define what's impactful in global surgery. So now we're really more talking about surgical education, transfer of knowledge, systems building, capacity building, and sustainability. Like these are all the buzzwords that we talk about now in global surgery. Grace, I'm sure you have lots to say.
Yeah, no, I totally agree with you. I think global surgery to me is the provision of care, surgical care around the world. And so, of course, that could be domestic, but I think with the disparity in the access to care that we see in the low resource settings, a lot of attention is on the low resource settings, which I think is appropriate. And I agree, things have changed so much from pure clinical care, which I think has a role. You know, we have moved away from that, but I think there is still a role for that to capacity building and enabling surgeons in other countries to care for their own people.
Yeah,
That's
and I think that, oh, I'm sorry. Um, that sort of brings to the second point that Kevin was asking about what is the impact or what do you see is a success in global surgery, right? And like Grace said, I think it really depends on what kind of program you're running. Like technically you are successful if you run a 1 week program where you go there, you do 80 cases or 100 cases, you're making an impact for sure. And you're doing clinical care, you're hopefully doing surgery that they will not have gotten otherwise. But it's a spectrum. And on the other end are more like global like health policy things where it may take years and years and years to make a tiny little dent in it, but that tiny little dent can mean improved surgical care for thousands of people. So I think it's very hard to define what is considered impactful or successful in global surgery. I think it really depends on what the program is and what the purpose of that program is.
Yeah, I agree with that. Kevin, that's a really hard question.
I know we go right for the jugular. We
Yeah,
know
you
you're
do go for the
surgeons.
jugular.
We're surgeons. We want to extract the juice,
Within the first 5 minutes.
right away. The first cut is the deepest, as one singer once said.
You know what's so interesting is okay, so I totally didn't know this, and I'm not sure if I'm allowed to say this on the podcast, but Behind the Knife is actually also doing a global surgery podcast series, which I totally didn't realize. And I
Oh,
think they just
okay.
dropped
How
this
funny.
episode like literally today. But I was listening to it today and I was kind of thinking, which I didn't really realize this about global surgery, and maybe this is kind of my ignorance, but I actually didn't think about the fact that maybe there's some people in the world who need surgeries who can never get surgery. So do you feel like you sort of see that where you go? And is that kind of what you mean by capacity building, or is capacity building more infrastructure? Or is it more education? I'm just kind of sort of curious about what you mean specifically about that.
Yeah, definitely. So lots of statistics kind of get
Grace,
quoted.
you can start.
So I think 5 billion people lack access to surgical care across the world. 30% of the global burden of disease is surgical in nature, and it's always operations that should not be that inaccessible, things like hernia repairs and C-sections, XLAPs for traumas, not things that are super complicated. So there are millions of people who are suffering disability or actually dying from very treatable conditions. So there very much is a problem. I think, one other stunning statistic is that 9 out of 10 people don't have access to a surgeon around the world. So there really needs to be capacity building, increasing the surgical workforce to even come close to addressing that problem.
Yeah, and along that same vein, it's not just there are so many variables that are limiting access, right? There's the limit of not having a surgeon in your general vicinity of 2 hour or 3 hour. And then there is like, does it, even if you do have one, does the surgeon, are they able to take care of your problem? And then there's the problem of can you actually afford the surgeon, which is, I think is another major barrier to actually getting surgical care. And for a lot of these countries, and especially when you're serving the most rural regions and the poorest regions, like one surgery will they call it a catastrophic health expenditure, meaning like one surgery can essentially bankrupt you and you would not be able to recover from that. And we're talking about like basic necessities of food or shelter or things like that. And there are millions of people who are in that kind of a position. So that one is a much harder question to address, or dilemma to address, because we're not economists and we don't know how to build that infrastructure or the economics of a country to make that better. But I think us as surgeons, the part that we can help with, in particular, is really about education, which then lends to capacity building of local surgeons. And then hopefully that means training more surgeons who can actually provide the care.
Yeah, I think these are all really great points. And I think, what we're talking about, I feel like all of us who are surgeons probably grow up in pretty privileged environments. So it's really hard to kind of imagine not having that access. But I think even when we think about our own patients, like how many times do we hear stories of, oh, I need to delay my care because I have to do this. And so I think that it does happen globally, but it also happens at home as well. So on this topic of surgical education, I sort of want to ask both of you, since it seems like so much of the work blends like surgical education and sort of what you're taking and how you build the capacity, what kind of models have you guys found to be particularly effective for training, and maybe even assessment in these low resource settings? And how do you adapt like curricula that we use here, or maybe you don't at all, I don't know, so they're more context appropriate, or how do you build that? Is this like more simulation? Is this more hands-on training? Is this kind of credentialing pathways? I'm just kind of curious how you guys take that abroad.
And
Um,
feel free to introduce your programs. With this question, it's kind of a good segue to hearing about GLAP and AllSafe. So, Linda, tell us a little bit about that.
Sure, I guess I'll go first. GLAP or GLAP stands for Global Laparoscopic Advancement Program. It's a long-term program that's done through SAGES with SAGES content and FLS testing at the end. Essentially, we have like a virtual component where people come on Zoom for multiple sessions over a span of 2 to 3 months. So they get familiar with the clinical content of laparoscopy. And then also at the same time, we're teaching them how to build simulators and how to perform basic laparoscopic skills that we perform in FLS. And that And then after that is when then we get on site for a 1 week course where we train them more. Now it's, in-person training of the FLS skills. And then as well as additional content that's about the basic laparoscopic procedures like lap appies and lap choles. And also a lot about like troubleshooting, like when you bring laparoscopy to a country that does not know laparoscopy well, it's not just, how do I move my hands in an operation, but it's about the tower. How do you set up the tower? How do you get the oxygen? How do you, what kind of instruments? How do you disassemble the instruments so they're sterilized properly? And so it's about training like the whole team and everything else that's laparoscopy for that for us as surgeons in the US, we just take it for granted because all we have to do is just step in and, scrub and then do our case. But for them, the surgeons there actually have to learn all of that stuff too. So some of our course content is related to that. And then at the end, then we do uh, most of our participants can and will take an FLS exam. And that's like sort of our way of assessing or proving that they have at least if they pass, uh, have obtained proficiency in basic laparoscopic skills, right? FLS certification in other countries means differently than here. Here, like 95% of people pass the FLS, and it's like a very basic kind of exam. But over there, one, they value it a lot because they don't have any other validated testing. And also, it's also suggests that they have some basic proficiency in laparoscopy that they can start performing. But we are also very careful to emphasize that this does not mean they can do a lap Whipple, or lap some whatever complex procedure. This is just basic laparoscopic skills that they have a proficiency in. So
Yeah, lots of similarities between GLAP and LSAFE, which is our program. I just wanted to say that I think kind of getting to the root of it, though, is that both of these educational programs allow for self-directed learning. So the learner can access all of this and kind of learn at their own pace. But AllSafe is very, very similar. So ours is an online platform. We have both cognitive and psychomotor training, similar to GLAP. So the cognitive will be a case scenario that involves patient selection, anesthesia, positioning, trocar placement, things like that. And then we will teach simulated versions of very familiar procedures like lap chole, lap appy, running the small bowel on simulations that are specifically designed for the low resource setting. So all materials that are very easy to source in that setting. And the box trainer is a cardboard box utilizing cell phone and laptop. So we hope that because the materials are easy to obtain, it's something that can be done without any kind of barriers. We're a little bit different in our assessment. So our assessment is via peer review, peers watching video uploads of performance of the operation as well as AI. So we have these AI models that will assess videos and give metrics back on instrument handling and tissue, respect for tissue, things like that. So that's our platform. The other nice thing is that with the peer review, learners are joining a community. So I think we've seen that it's difficult to learn anything, but particularly something like laparoscopy in the low resource setting, which is very new and very difficult. When we all trained, it's not easy to learn these laparoscopic skills. So having a supportive community, I think, has been really key to the success of our program. We see that people love to encourage one another and share tips and tricks, and so that's been kind of a really helpful aspect of our program.
I love that. And so it's so funny because I feel like Kevin asks all the high level questions, but I actually, because he knows so much about surgery already, but I feel like because I don't know as much about it, I'm going to ask all the low level questions.
Yeah.
So it seems like, a lot of the people that you're training are already kind of familiar with some open surgery techniques, or maybe they're in a training environment, or they're already practicing surgeons. So then they're trying to transition their skills and build capacity for potentially minimally invasive surgery. So how long on average would it take to kind of like train a surgeon, or how long does it take for them to go through the program and be able to actually, do a lap chole at their own institution? I'm sure that's kind of very dependent on, where they are and what kind of resources they have, but I'm just kind of curious, once they finish the program, what does that look like for them?
Yeah.
Yeah,
Go ahead,
I
Linda.
can I can talk about more fundamental levels of that. The our program, we the goal of our program is not to teach them how to do a lap chole or lap appy, right? At the end of our program, we're not going to be like, all right, now go to your community hospital and you're going to go do your first one without anyone watching over you, because that just sounds dangerous. But the goal of our program is to give them the basic skills of how to maneuver in a laparoscopic case, and the safety concerns and the risks that they can potentially run into. So technically, at the end of our program, these are skills that can be applicable to any kind of surgery. And I would say that, um, to actually let someone essentially just freely do a lap appy, I think that requires a lot more proctoring and things like that, which I think probably maybe Grace's platform has a bit more of that,
Yeah,
maybe.
our platform, because we're teaching the direct operation, I think I know a lot of FLS, for instance, is going to be a lot basic tasks and skills, which I think are very important for becoming facile at laparoscopy. But our platform is directed to general surgeons who are already doing these operations open, so they know all the surgical concepts. They know, how to handle tissue, how to get hemostasis. So it's kind of I would say maybe a little bit more advanced. And we fully understand that this is just a tool. We don't expect surgeons to do our lap chole module and then a month later do a lap chole. So this is hopefully one of many other items that they're using to learn how to do these operations. But we've seen just within our own experience that it takes about a year. So they're going to work on this platform for about a year and hopefully get other touch points of education from maybe visiting surgeons or colleagues that they might know who have started to tap into laparoscopy. So over the course of the year of gaining all this experience, they can hopefully start to do some very basic lap cases. And, I give that kind of metric of a year because we actually have people who are now part of the AllSafe team who started as students, learners on the platform who are now actually doing laparoscopic cases. So it's actually really, really cool to see, but it does require patience and other touch points as well.
Yeah.
Yeah,
And I would
if I
say,
could, oh, go ahead, go ahead.
oh, I was just going to say that I think what after they have done like a program like GLAP or like an AllSafe program, I think the next step that many of the surgeons would do, or hopefully, for our GLAP program, we don't provide this part, even though we're about to start doing this part, which is a bit of teleproctoring. And at my site at Mount Sinai, Uganda, we have been teleproctoring a surgeon there in laparoscopy. And to answer your question, Jenny, like for him, we've teleproctored him for probably over 30 cases of lap appies and lap choles. And of course, in the beginning, it is extremely slow, right? It's like 4 hours of like, no, cut there, no, 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 move over just a little bit, no, pull back, like a lot of that stuff. But now he is pretty proficient. Dr. Joseph Moy, he's like, he can do a lap appy on his own perfectly fine, and he can do a lap almost all the normal, not horrendous gallbladders on his own. I think the difference between training a resident here versus training a full-fledged surgeon there is that the surgeons there know surgical anatomy, understand surgical concepts, and what to do. The problem is they're just trying to translate their skills from being an open surgery to laparoscopy, right? And like where to pull, how much to pull, where to cut, how much to cut. And that transition is so much easier to do than when you're training a resident, where they're both learning the skill of surgery along with the skill of laparoscopy. So I think the learning curve is much shorter for these surgeons to transition from open to lap. But it does require a lot of repetition in order to get to that level.
Yeah, if I could share one anecdote of an exact example of what Grace talked about, there is a surgeon who was actually in his senior residency. It was, I think, a third year or fourth year, who came to a different program. It was another organization that I do laparoscopic training with, and he lives in Nigeria. And so when Allsafe came to Nigeria and we did a course with him, he of course came, and it was closer than the other place we went to. But we've since gone back 2 other times in this other organization. So now he's a first year faculty, and he went through most of the modules. He definitely went up through the gallbladder module, and just last month sent us videos of his first 2 laparoscopic cholecystectomies as a junior surgeon in a rural Nigerian hospital. And that whole process started in 2019. So that's kind of the time frame we're talking about. Like, it's a year to go through the program, but then it's all the other touch points. He looked for other things to go to. We would send, it's the community, the fact that he stayed in these WhatsApp groups where he was saying, is there another conference coming? And so these are the kinds of things that require longitudinal relationships. And I think seeing him kind of post that video of him doing a lap chole with one monitor looking over his back. I know everyone would have been, but hey, they have one monitor. He's looking over his shoulder and he's doing a lap chole, and he sent it to both groups. Grace got that video, and the Gene Code group that I sent it to did as well. So it's just great because that impact is going to be so great for the next, because he's young. He's like probably in his, late 20s. So he's got decades ahead of him, and he's just going to keep getting better and better.
Yeah, Kevin, you bring up a really good point of like the motivation of the participants is incredible. Like these people have tried, and look, I tried to identify training courses everywhere in their country, outside their country, in India, whatever way they can possibly get to get these training courses. And so then when they get it, they are so happy. And it certainly makes us feel great. And I've had some very similar stories of, they still keep in touch with me and they'll send me their first lap chole. And then that was like, we went to Ethiopia in 2023, and then one of the guys, he did his first lap chole a year later, and then just yesterday he sent me a video, and also it was like a news article of him doing his first hiatal hernia repair laparoscopically. I mean, I was pretty impressed, but I'm sure between 2023 and now he has gone and tried to identify all other kinds of programs or shadow people, operated with other people who did laparoscopy in order to get to this point.
Yeah, I love this like concept of longitudinal mentorship, because I feel like that's kind of what we're talking about here. And I think, even here we're having a lot of these conversations, right? About robotic surgery, adoption of new techniques, like how do you learn things as like a practicing surgeon who maybe wants to learn a complex technique. And I think we talk a lot about that in the hernia world actually, because we're trying to develop similar education. So I think we can probably really look to you guys and see how you're training other surgeons and probably learn a ton about how we can continue this like ongoing surgical education and all these other areas as well. But I love that idea. I feel like it sounds like longitudinal mentorship is and that connection and that community that you build is probably really important.
How much do you both chuckle when you read articles in the Journal of American College of Surgeons that are titled "Is Laparoscopy Dead?" Grace and Linda, like, what do you like? What
I
do you
mean,
think?
it's
What do
not
you
going to be
think?
dead. It's not going to be dead in Africa
Yeah,
anytime
yeah,
soon. I mean, it's
yeah.
burgeoning, and I mean
It's
that
burgeoning.
what is really kind of driving all of this is that the surgeons in that setting, they're like hungering to learn laparoscopy. So they are happy for all these courses, like Linda said, because they just so strongly desire to learn how to do laparoscopy because I think they recognize that it's good for patients, and it's especially good for patients in the setting in which they live. I think the low resource setting may be sort of the savior of laparoscopy. I mean, I see robotics really kind of becoming huge here in the US, but I think laparoscopy will always have a place because there are places like Uganda, there are places like Nigeria, and I think laparoscopy will continue to grow there.
That's great. So I'm going to shift to another advanced topic that Jenny's going to be mad at, but I want to talk a little
No,
bit about
not mad, just impressed.
yeah. Maybe let's talk about ethics. What safeguards do you put in place to ensure number one, patient safety, trainee safety, or in kind of these austere environments, trying to do complex things sometimes? How do you handle the consent, the follow-up, case selection? What are some of your processes along, specifically when you're doing surgery there, when you're invited to do surgery there? Why don't you start,
Grace, you want to
Lynn?
answer?
I can start. So I think going back to for our particular programs, and I'll just narrow it down to our particular programs. Again, we are training general surgeons who are very proficient in doing all of these procedures that we're trying to teach laparoscopically open. So I think they have great respect and regard for what is the operation that they're doing for patient care, caring for their own patients. And I think that in and of itself is a big safeguard. And if they need to convert, they can convert and do the open version of the operation just fine. Um, so I think that is something that makes me a little bit easier about this, that I just trust my fellow colleagues that we're all trying to do the best thing for the patient and have a respect for our limitations or when things might not be going right. That having been said, I think there probably is the temptation to maybe kind of get in a little bit over your head when you're trying new things. So, like I said, I think that AllSafe is a touch point among many other modalities of education. I think our assessment that we have on our platform is pretty good with the peer review and with the AI, but it's not the be all end all. And, again, I'm just hoping for other touch points and, again, importance of the community and longitudinal education.
Yeah, I for Kevin to address your concern about, I guess, the legality and the patient safety of operating abroad. In many of these countries now, unlike I would say probably 20 years ago, many of these countries, if you were to scrub, you actually have to have credentials there and licensing in that country. So for Uganda, for our site from Mount Sinai, I do have credentials there to operate. So technically, like I could be responsible for that patient. But in general, like what Grace said, we're visitors, right? And it's the local surgeon who is technically responsible for everything that happens in the operating room. And so that's we're sort of deferring to them for that aspect of it. Now, teleproctoring, on the other hand, is also very interesting and has a lot of its own medical, legal, and concerns and everything. But I think that is still in the works, and no one has the real, like, structured definition of how you should go about it and things like that. But generally, it's still like the surgeon who is doing the operation in that local setting is the one who's responsible for the patient because they are full surgeons with licensing. So.
Yeah,
Yeah.
it's a tricky area, Kevin. I think fortunately, it's not so super heavily regulated yet because I think that would actually impede what we're trying to do and teach. But I do think there needs to be some level of regulation, but we just haven't gotten to that point in credentialing as well. I think as these educational platforms roll out, I think that whole credentialing piece is the next in line that needs to be
Yeah.
tackled as a global surgery community.
Yeah, I think
And I,
especially as you think about the variety of, I mean, every country's different, every Uganda is different than Burundi, that's different than Kenya, that's different than Nigeria. And so I think you know, for many people, it's like Africa is sort of like this big continent, but it's a continent of many different countries that have different regulations and different ways of doing things. And it's one paper does
Yeah,
not get you through each of the different
right.
countries, as
No,
Grace and I have learned many times at the customs line
yeah, for
in
sure.
these.
And I guess, speaking of that, I guess there's this question of alignment, right? So then when you go to all these different places and you're trying to bring a similar program, how do you make sure that your goals really match, the goals of the institution you're going to, or perhaps the leadership and some of the governance from these local host institutions? Is this something that you sort of talk about ahead of time that you really tried to figure out? Do you sort of change the goals of your program if they have different priorities, or how do you guys sort of navigate and balance that?
I think you bring up a really good point, and this is all about like relationship building in global surgery. And I would say this is the number one and most important skill set to have as a global surgeon, which is getting what you want to happen be aligned with what they want, right? And I think that in the past, there's been so many programs where essentially it is what the high income country surgeon wanted and imposed onto the low income setting. And they're like, oh, we know what you want. This is what you want. And those kinds of programs tend to never survive for very long because, they don't have the buy-in of the local institution, local faculty, local whatever. But now I think now there's a lot more emphasis on sustainability and actually hearing the voice of the local community. And so, like for us, for GLAP, what we do is our program is just slightly different depending on where we go. Like there are certain areas where for example, for Latin America, there are some places where they want to do more curriculum development. They want to learn teacher skills as opposed to pure FLS skills, or some other areas where they're like, we don't even have capacity to build a curriculum. Just give us the basic skills. That's all we want. So we sort of tailor our programs based on what they are looking for and what they're interested in doing. But I think overall, beyond.
I agree with everything that you said. And I think, what you said is going to be there. I think having, folks from all over the world on your team is super important to you because that helps to cater the program to the desires of the target, the learner group. So our team has lots of learners now, part of the team, faculty, people who actually learned laparoscopy through AllSafe or a program like AllSafe. So we know exactly how to meet the needs of our learner group. I agree with you also. We have to cater the programming to the different geography, the different type of learner. Is it faculty? Is it resident? Is it gynecologist? Is it general surgeon? So all of this is relationship building, trying to figure out what we all want to do together, collaboratively. So it really the relationship is kind of the underpinning of the success. Totally agree with you on that.
And so since you're going to so many different places, I'm sure there must be so many different cultural differences, so many different norms that you're seeing. How do you guys navigate that? Are there any like, tips for, those of us who may be going to different places, or even just to kind of keep an open mind about how to approach some of these cultural differences?
I think the key is humility. I think that's important no matter where you go. I think we're learning from each other. We're bringing something, but they're also bringing something too. So I would say humility will um, surmount any cultural divide, no matter what country you're in.
I would just add to that, there are lots of programs, including Mount Sinai, that send residents abroad to these many of these countries for a rotation. And at Mount Sinai, we actually give them a cultural humility course before they are allowed to leave. And it has nothing like I completely trust their surgical skill. I know they're going to be great. Whatever surgery they're doing out there, they'll be helpful. They'll know their part, they'll do their part. But it's actually the cultural humility part that I am concerned about because and that is much harder to navigate than just being in the OR. And that requires, like Grace said, really sort of understanding yourself and understanding where you're coming from before you understand where they are at, right? Like all these preconceived notions that we have of what is right or what is the right way to do things, it's completely like it's all cultural, it's all relatively based. So out there it's very different. And I think I tell my residents a lot that they just need to tread lightly. Don't make a scene in any kind of way in what you're feeling, what you're behaving, or what you think is the right way to do things, or how you think that it should go, and just watch. Do a lot more listening than talking, and then you will see the cultural differences and you'll be able to navigate that much easier than just being really upfront and always talking and always like showing what
For the readers out there, and I would not include myself among them, but I did actually read this book. So I was encouraged when I was living abroad in Abu Dhabi for a couple of years to read this book called The Culture Map by Aaron Myers. Very, very great resource for anyone who is navigating multicultural relationships. And kind of what it does is it sort of maps out traditional ways that certain people from different cultures handle feedback, for example. Like there's certain people who want direct feedback and others who want it to read the air. Like these are the kind of things that kind of help you see where you are in that map and not necessarily look for ways to be more like that person or like that culture, but understand that in this area there's a big gap and you're gonna have to work hard on that area. And so it was a great read. And I saw actually a long-term missionary last week at the PAX conference quoting a lot of Aaron Meyer's work using the culture map. And I don't know if you saw it or not, but it's a great resource. So anyone who's considering going over, it is a riveting read, even for a non-reader like myself. So, um,
I'm putting it on my audiobook
yeah. It's
list
the
of
thing
things
about
to
it. I
listen to
think it
when
would
I
be
drive.
harder. It's harder as an audiobook because it's actually a visual
Oh, is
map.
it? Okay.
Like, I mean, it's written, but then there's a map, and you'll see like
Mm.
where people are. You can do the audiobook but I would look to see if you can get the book too for the actual like where people line on things. So anyway. So we're nearing kind of the end, but we have a couple more questions. But I'm going to hit another hard one: funding and burnout. So these are two kind of rough, tough topics. So how do you support this work financially? How do you protect yourselves and your teams from fatigue, moral distress, especially in these challenging environments. So what are some things that you've done to raise funds or find funding, and number two, protect yourself and your teams?
Right, I guess I'll go first on this one. So funding, All Safe is just blessed. We're a unicorn. We got funding from the Intuitive Foundation, as Kevin is well aware. So we basically got granted about $1 million to roll this out. Um, so we've been very fortunate. I know that it's rough times in funding. I I'm at that point now as the team lead where I'm going to have to start looking for more funding. And truthfully, I think I'm going to look towards maybe trying to get faith-based organizations to fund the work because I think we have a lot of shared goals. And then with regard to burnout, um, I think doing this work is actually always revitalizing to me. And I'm sure Linda feels the same way. I mean, the travel to Africa can be very difficult, but I always come back more energized than when I left, even, after 25 hours of being on a plane. So I think there's something protective about this work that gives me and gives energy to me and kind of restores my love for surgery in many ways. So that's what I would say.
Um, I'll tackle the funding thing. So funding, the GLAB course is funded through SAGES and also through a philanthropist through SAGES. So that's where but we have very, very limited funding. Um, and we are always, I think as the chair of global affairs, this is like my biggest fear and my biggest conundrum, which is like we want to reach as many sites as possible, but that just costs money. And how do we do that? So for us, unfortunately, we don't really have other big funders. So we have to figure out, we do MOUs with local sites so that we share some of the cost of putting up these courses. We ask the participants to pay a certain cost to do the courses, because otherwise there's just no way for us to go to Uganda, Ethiopia, Namibia, Zimbabwe, all these countries with the very, very limited budget that we have. But we're always looking, we're like always looking for industry funding or other society funding or philanthropy funding, anything. So, but it's very challenging. And as for burnout, I would say I completely agree with Grace that I love this. I'm very passionate about it. This is like what I live for. So I don't feel burnt out at all. But I really do worry burnt out for many of the other people who are involved in this process, because a lot of them just don't have as much time as I do to devote to this. And the little bit of time that I really want to make sure that they feel like they're valued, that their efforts are valued and that they are actually making a difference. Because I think part of burned out is both the fact that you are putting in so much time, but also that if you don't feel like all that time you put in is actually like impactful, then it I think it burns you out a lot faster. So that's what like we really try and do. And we also have to be like very selective about knowing our committee members or people who want to come on the trip, and sort of hand selecting who goes to which site, because some sites are much harder to handle and much more difficult to spend a week at compared to other sites, which is they're much more familiar. Maybe they're culturally a little more familiar with, and whereas, or like in terms of living environment, living in a much worse kind of like hostile kind of housing as opposed to a good hotel, like all these things we have to take into account. And based on like where this faculty member is at, we try and put them in the space where we feel that they will not get burned out just even by being there for a long extended period of time.
That's great advice.
Yeah. So I mean, thank you guys so much. This has been really informative. I feel like as somebody who doesn't know a lot about global surgery, I definitely learned a ton. And so I'm going to pivot to some lighter stuff. And so before we go, we always do a fun segment called We Are the Sages segment. So can each of you guys share with us your most memorable Sages moment?
We are the world. We are the world. We are the sages. We are the sages. Sing it, everybody. We are the ones who make you bright our days. So let's start treating. Have you had a good time tonight? There's a choice we make. We got a lot more coming. We are good dancing.
Linda, you get to go first this time.
Oh God. Oh, I need some more time to
All
think about
right.
this. It's Grace, you go. Let me think.
My most memorable moment would be when Dr. John Mellinger and Dr. Adrian Park asked me to participate in the presidential session. This is a few years ago in Montreal. I
Yeah.
was so beyond honored to be on the stage with them. Um, and I was just truly, truly touched. One of the speakers who was supposed to be there was Dr. Jacques Abele, who is a surgeon from the Democratic Republic of Congo, but he was unable to get a visa to attend the conference in Montreal. But he's actually coming to the US, or he's in the US, and he's
Yeah,
coming to
he is.
Ann Arbor next week. So he's actually going
And,
to be staying at our house.
and
So
to
I'm
Cleveland the week after that.
yeah,
So
and
I
then
gotta
heading down to Cleveland to spend some time with Kevin. So I am so excited to spend time with him and really get to pick his brain about being a surgeon in the DRC and just really be blessed by him. I hear that he's such a incredible person. So anyway, so that was my top Sages moment.
All right, Linda, does that give you enough
Uh,
time?
yeah, I guess so. This is the one that came up. It's not as awe-inspiring as Grace's moment, but I think it was when I sort of first started joining Global Affairs Committee, and I was just like a dinky, just finished residency or fellowship kind of person, and I just remember seeing all the other global surgeons on the community and being in awe of all of their great work and how like how much knowledge they had. And then it was like they were talking about, uh, asking for volunteers for something or another. And all I can do in the back was like, me, pick me, just pick me. And it was a fun moment, but I remember how I felt and like the excitement that I felt that I could actually be involved in something that would be very impactful in the global surgery world. So I think that's the nice thing about SAGES. They really, give people opportunity to pursue things that they're really interested in or passionate about, and provide them that kind of venue to explore that passion.
Very well put. We're going to end with a rapid fire. So this is a first thing that comes to your mind, okay? And each of us will call on you individually. The theme is global surgery, okay? So so
How appropriate.
Grace, the one instrument or tool you can't live without on a global trip. Go.
Needle driver.
Okay.
Okay, Linda, the most underrated skill in global surgery.
Underrated skill. Oh boy. Oh gosh, this is hard. Um,
Quickly.
oh God. I'm not good at this kind of stuff. This is terrible. I would say, oh God, can I get a pass?
Okay, pass.
Yeah.
Grace, most underrated skill in global surgery.
These are like deep, hard questions.
I
I think
know.
this is a boring answer, but I'm gonna say team building. I don't know if it's underrated, but it's definitely vital.
Okay.
I love it.
Linda, a misconception about global surgery you wished we'd retire.
Ah, that you can, is this bad to say, that that you are impacting more the global community with 1 week trips than you are impacting yourself.
I love it.
Perfect.
All
Love it.
right, Grace, one resource you'd recommend for listeners who want to learn more.
One resource, I would say join, it's not a resource, but maybe join a committee, a global committee in SAGES or ACS or any of the other big societies, and then that connects you like almost immediately to global surgeons.
And Linda, if you had a magic wand, what systemic change would you make tomorrow to advance safe surgery globally?
These are really hard, rapid
Wow.
fire questions.
World peace. Just
Evan
say
going
world
for
peace,
the jugular once again.
Give everyone a laparoscopic tower.
Ah, it's okay. See?
That's a good one. I like that. All right. And for the end, we have a lot of people who listen to our show who may be early career surgeons, trainees, or just health professionals who are really eager to get involved in the global surgery community. So what's step one for them? What can you recommend other than I mean, it sounds like joining a community or potentially a global surgery committee at a national organization, but how else can they get involved and what should they do?
So my advice, so we get this question a lot from students and residents. So as much as we kind of were belittling or, saying that the clinical trips aren't really the way to go ultimately, I think it's important for people to get started with that. So I would say get on the ACS Hope website, find a clinical experience, whether it's 2 weeks or a month, because you need to really know what you're getting into. I think it's hard to think about education and capacity building if you don't really understand the climate. And then I would say join one of the committees, and then that will connect you in with people and um, the ability to intervene more on systems and education versus just a clinical trip. Linda,
Linda?
do you have anything to
I
add?
I completely agree with you. And I do not want to be poo-pooing these like 1 week like mission trips and things like that because I do think they serve a purpose. There is a spectrum of ways that people can contribute to global surgery, and some people can only afford enough time for 1 week, and they're still doing something, right? They're contributing in their own way. And I also feel that these trips are excellent for medical students or residents who want to explore if global surgery is the right pathway for them. And I always
It,
tell, oh, go ahead.
no, go ahead. Go ahead.
Oh, I was going to say, I always tell my med students who are interested, like, whatever experience you can get, it doesn't even matter where or how long or when. If they're giving you the opportunity to go, just go, and see what it's like and see if this is something that really drives you and that you're passionate about. I mean, I personally think that that is really the only way to actually get real exposure, real understanding of what this field is about.
And I'm going to add one thing, which is get some skin in the game, which usually means pay. You know, find an organization if you can't go that seems worthwhile to you and donate. I think once you start to add that into what you're adding within what you're paying for, you will feel more connected to it. And even if you're a med student, even if you're a resident, it doesn't have to be millions of dollars. Put, a little bit. Like don't drink two frappuccinos for a week for a couple days and
Yeah.
just get some skin in the game and you will feel connected.
Awesome. Well, honestly, I want to thank you, Linda and Grace, for your time tonight, and for your candor, your wisdom, and honestly for all the incredible work you're doing. I think this has been really informative and awesome, and such a call to action for, I think, hopefully some of our listeners. For our listeners today, if this conversation resonated with you, definitely consider supporting a partner-led initiative in your region, just as Kevin had mentioned, mentor a trainee or integrating global perspectives into your local practice. You can learn more at the SAGES education and opportunities at sages.com. And I think we'll definitely link the programs that Linda and Grace are part of in our show notes as well.
and it will be sages.org, not
Oh, sorry.
sages.com.
Sorry.
We're
I don't know why I said sages.com. Now
so
automatic.
www.sages.org,
Like, wait a minute.
and
Do I know this?
we're gonna put our show notes for AllSay, for GLAP, for the ACS Hope site as well, so that people can hopefully use this podcast as a resource as well. And thanks everyone for listening. See you again next time.
Yeah, thank you.
Thank you. Thank you for having me.
And that wraps up today's episode of Sages Stories. You can view the show notes for any links to sites we referenced today. Visit sages.org for membership information and for the most recent news from our society. Follow us on Twitter at sages_updates. Make sure you hit the like button and subscribe so you don't miss any future episodes. See you again next time, and remember, you can't spell minimally invasive surgery without SAGES.